Hello students, welcome back to my channel. So we are studying gastrointestinal system from the first aid, and today's topic is gastritis and peptic ulcer disease. So let's talk about the gastritis first. So gastritis are two types. There are acute gastritis and then we have the chronic gastritis. The acute gastritis, in acute gastritis, the erosions are caused by mainly three things, that is NSAIDs, burns and brain injury. You need to remember that the Kernig ulcers causes the burns and the Cushing ulcers is caused by the brain injury. Then we move on to the chronic gastritis, in which there is usually the atrophy, there is hypochondria that lead to hypergastrinemia and intestinal metaplasia, and that can lead to the gastric cancers. So there are two types of chronic gastritis, H. pylori and autoimmune. The H. pylori gastritis is the most common one that can lead to increased risk of peptic ulcer disease and also increased risk of malignant lymphomas. They affect mainly the antrum first and then they spread to the body of the stomach. Then we have the autoimmune that lead to the autoantibodies, T-cell induced autoantibodies to the hydrogen and potassium ATPase on the parietal cell and to the intrinsic factors. They increase the risk of pernicious anemia. Autoantibodies increase to these parietal cells and to the intrinsic factors and lead to the pernicious, and they basically affect the body and the fundus of the stomach. Now there is one more disease that is known as a mini-triad disease, that in which there is a hyperplasia of the gastric mucosa that lead to the increased mucus production. As a result, there is protein loss and decreased parietal cell production, atrophy with increase in acid production. So in the meningitis disease, they usually the precancerous and they presents with the mnemonic wavy, that is the weight loss, anorexia, vomiting, epigastric pain and edema. So this is the mnemonic for the meningitis disease, in which there is hypertrophy rugi, that is giving a wavy like brain gyri, and this is a hyperplasia of the gastric mucosa. Then we move on to the next topic, that is the gastric cancer. So the most commonly cancers of the gastric cancers are usually the gastric adenocarcinomas, lymphomas, stromal tumors, carcinoid tumors, which are rare. They are very early aggressive local spread with a load and liver metastasis, but they present late with the symptoms that can be remembered by mnemonic weapon, that is weight loss, early satiety, abdominal pain, obstructions, as well as in some cases acanthosis nigricans. And then there are two types of gastric cancers. The one is intestinal and the other one is diffuse. The intestinal gastric cancer is associated with H. pylori, dietary nitrosamines, tobacco smoking, achondria, chronic gastritis, and they are usually present on the lesser curvature and they look like ulcers with raised margin. And the ones that are present, the diffuse one, are not associated with the H. pylori infection, but their most common cases are due to the mutation in the E. cadherin protein and that the signal ring cells, and the stomach wall is grossly thickened and leathery, that is known as the Leonitis plastica, that is present in the diffuse gastric cancers. So there are nodes, the visual nodes. We already talked about the visual and the systematic Joseph nodule in the previous video in which we discussed the lymph node associations. There were two more, Krukenberg tumor, there is a mets to the ovaries, usually bilateral, they are abundant in secreting signal ring cells. Then we have the Blummer shells that are usually palpable mass on the digital R examination, suggesting the metastasis to the recto-uterine pouch, that is the pouch of Douglas. So they're usually the palpable mass on the digital rectal exam, suggesting the metastasis to the recto-uterine pouch. So these are just the four things that are actually the that are actually the cause. Then we move on, then we have the peptic ulcer disease. So there are two types of peptic ulcers. There are gastric ulcers and then we have the duodenal ulcers. So if we talk about the gastric ulcers, they can be, the pain with the gastric ulcers can get greater with the meals. The H. pylori is more commonly involved in the duodenal ulcers, and there is a decreased mucosal protection against the gastric acid. And the cause of the gastric ulcer could be NSAIDs, where the duodenal ulcers could be the Zollinger-Ellison syndrome. And the carcinoma's risk is more in the gastric ulcers, and the biopsy margins are, we take the biopsy to rule out the malignancies in the gastric ulcers. And the age group that is involved is 50 to 75 years, and a lesser curvature with the antrum usually involved in the gastric ulcers. And the most common complication of the ulcers is usually the hemorrhage, and two other complications, the obstruction and the perforation. So the hemorrhage is usually Posterior ulcers and the duodenal ulcers are usually predisposed to the ulcers, whereas ruptured gastric ulcer on the lesser curvature of the stomach, usually the bleeding is through the left gastric artery, and the ulcer on the posterior wall of the duodenum lead to the bleeding from the gastroduodenal artery, that is the branch of the hepatic artery. And if we move on to obstructions, so it can cause the pyloric obstruction of the pyloric channels and duodenal obstructions. Then perforation are more common in the interior wall of the duodenum, and they can perforate in the interior abdominal cavity and potentially leading to the pneumoperitoneum, and from there can move to the posterior subphrenic spaces. And if we see the air under the diaphragm, that is indicating the pneumoperitoneum, will refer pain to the shoulder with irritation of the phrenic nerve. So next thing is the perforation of the stomach posterior wall, that is the lesser sac. Then we name indication of the truncal vagotomy is actually to decrease the gastric acid production and increase the pepsin secretion. So then there is the acute GIT bleed. There is an upper GIT bleed and the lower GIT bleed. The upper and lower is being divided by the proximal to the ligament of Treves, there is a suspensory ligament of the duodenum, and the distal to the ligament of Treves is the lower GIT bleed. The upper GIT bleed represents with hematemesis and melena, and that is associated with the peptic ulcer disease as well as in the varicose hemorrhage. And the lower GIT bleed usually present with the hemochrhasia associated with the IBD, diverticulitis, diverticulosis, injury dysplasias, hemorrhoids, anal fissure, and cancer, that we are going to talk about in more details in the next video. So this was all about some of the pathologies of GIT system. Keep watching my videos to make your learning easier. Don't forget to subscribe to my channel and like this video. Thank you.